Well with Adina. This is our COVID-19 Community Town Hall update. So thank you very much. These are very unprecedented times in this time of the COVID pandemic and the Delta surge. We at Adina are experiencing incredible volumes, record volumes, as all of Southern Ohio and all of Ohio is as well. We're no exception to the overwhelming demand for care. We want you to know, though, that the safety and health of our patients, our providers, and our staff is of the utmost importance to all of us here at Adina Health System. Your safety and providing high quality care for you is our #1 priority. We're at a very critical time right now, and we thought it was very important to bring you information that you can trust. And with us today is Jeff Graham, our CEO and President of Adina Health System, Dr. Kirk Tucker, our Chief Clinical Officer, and Dr. Wael Haidar, who is the Medical Director of Infectious Diseases. Thank you so much for joining us. And this is a very timely session.
Absolutely.
I want to remind our viewers that if you have questions, please submit them into the comment section and we'll address those as quickly as we can. So to start off with, Jeff, I know that you have been at the helm for the last 19 months through this pandemic. What are some of the key points that you want to be sure that our viewership is aware of, and what Adina is doing to keep our doors open and available for patients?
Yeah, sure. So, as you said, 19 months. It feels longer than that. The pandemic has been here. We've seen it at peaks before, earlier in the year. And then it got to a point where I think we had, maybe one day without any COVID patients in our hospital, one day. But obviously we're in a different place now. But we've been preparing, as I said on other broadcasts like this, for this before it ever hit shore. And so we have continued to have our incident commands. We've continued to learn as this pandemic has continued to grow. And just to tell the community, we're still doing what we were doing 19 months ago. And we're doing it even better. Every day we get better and better and better. But the focus, and I can't emphasize this enough, is the focus of the organization, the staff, the frontline staff, the nurses, the respiratory therapists, the techs, all those people, they're giving it 150% every day. And we're tired, but I can tell you the focus and attitude of our caregivers, our physicians, are just as strong as they've ever been.
That's comforting. They're up against a lot of pressure and a lot of threats. So Dr. Tucker, clinically, in the operational side of the health system, what have been the biggest challenges to meeting this pandemic need?
Yeah, so Adina Health has a large footprint. We're 9 counties. We serve 9 counties now, 4 hospital systems in those 9 counties. And so space isn't so much the issue for us, the number of beds or where do we place a patient. Most of the health systems that we communicate with on a daily basis are talking about worker shortages. So this is critical people necessary to providing the good care day to day to people both here with COVID and people that are here for other reasons like strokes and heart attacks. Certainly that is nursing staff, patient care assistants, respiratory therapists, right on down the line to lab phlebotomists, everybody else that's involved in care. And all of those resources now day to day are being stretched very thin by the sheer numbers that we're seeing here within the health system. And just today, the irony is that we reached a new milestone here within the health system of 90 COVID inpatients. During our last December-January peak, when we were on the news a lot doing this stuff, we peaked at 60. As a point of reference, Ohio State reported that they had 93 COVID inpatients this morning. So the health system is dealing with unprecedented strain on our inpatient ability to provide care to all of these people. These 90 folks today represent half of our current inpatient census. So half of what is admitted to the hospital today is COVID related. People here with COVID pneumonia and respiratory failure. So Very serious.
Yeah.
That doesn't include the Adina at home.
Correct. So we've put in place some other measures to try to decompress this incredible inpatient surge, meaning people that have come here and received their treatments and are placed now on oxygen, but have gotten the remdesivir and the steroids have been started. We're trying to send those folks home with this program called Adina at Home, in which we still follow with them twice a day on how they're doing. They have a discharge follow-up visit with a physician or a nurse practitioner the day after discharge. And it has allowed us to take 40 or so of the less sick people on the floor and get them home to recover and wean slowly off oxygen, which has been critical for us to be able to keep the door open so that when the next sick person presents to the emergency department very, very ill, that we can say yes and we have a bed waiting for them.
What are some of the creative ways that Adina and the staff of all of Adina are responding to help support the caregivers that are at the bedside?
Well, what we're seeing, one of the things operationally that we've had to do because of this tremendous spike, if you remember a little over a year ago, we got to a place where we were shut down, right? We're not shut down this time, but we are not doing elective inpatient type procedures here at the health system currently. We're doing emergency procedures and regular outpatient where you're going home same day. But if you require stay, we're having to postpone some of those procedures. Some of the creative things that we're doing right now is, Dr. Tucker mentioned the staffing and shortage of staffing and the stress on all of staffing. We have people from, whether you're in a clinical setting or you're not a clinician, you're grabbing a mop, you're grabbing trash cans, you're carrying supplies, you're changing hand sanitizer. We're seeing people from across the system, everybody jumping in from their regular job into wherever they can help with what they're qualified to do. So we're seeing a lot of creativity in that way. And the other point I want to bring, because I know I've been asked this question, the shortage that we're seeing in staffing, you hear a lot of that, and there's those out there that say, well, it's because you're mandating the vaccine. No, we're not. We're not mandating the vaccine. We are strongly encouraging people to take the vaccine, but we have not mandated. So we do not have people resigning their positions. There's a nursing shortage and other shortages across the country, and we're recruiting extremely hard, competitively, to find more and more people. But it's really the influx of the highest numbers we've seen that's really driving all the stress on the organization.
Okay, so the vaccine mandate you've addressed. What about testing? I know that the Medicare and Medicaid mandate, the president's ruling that if you receive these funds, you either have to be vaccinated or you have to offer testing. So I guess, Dr. Tucker, where is that process?
So those are specific mandates. Either get the vaccine or you're tested on a weekly basis for employers in communities with over 100 employees. They carved out healthcare providers from that exemption, and we're waiting on the final details of that order. But at some point in time, and our current best guess is about 70 to 75 days, that there won't be a choice given to all major health systems nationwide, that the employee workforce will have to be vaccinated or not be a part of the healthcare team. Now, there's a lot of pushback being laid before this order, how it will be implemented in the specifics and what will be allowed as an exemption, such as a religious or a valid medical exemption. What Mr. Graham is referencing is there is no rush on our behalf to rush into this and scare people at a time when the workers are so critical to our day-to-day operations. So we are watching on a daily basis what this mandate means coming from the executive branch of the government. We will be in full compliance with it when that time comes. But at this point in time, we're not taking preemptive action other than good measures of recommending vaccines, encouraging people to get the vaccines. Absolutely. And we do have universal masking in place. Anywhere in a healthcare setting, you must enter and be wearing a mask until you leave.
And
Okay.
if I could add something that we were talking about prior to coming on here today, something that we've started doing at the system level is being able, and hopefully some of you all out there have seen that, is keeping the community updated on the volumes that we're seeing in the hospital. But also we get a lot of questions. Well, are your patients vaccinated that you're seeing? Or, what are the majority of your patients? Are they unvaccinated? And as you can see on that chart, the majority of patients that are in our hospital, almost the total majority of patients are unvaccinated. So you can see the impact that the vaccination plays. Is it guarantee you that you'll not catch COVID? Absolutely not. The flu shot doesn't guarantee you're not going to catch the flu. But the effective rate of this vaccine has made a tremendous impact, and that's why we strongly recommend that that everyone take the vaccine.
And I have the numbers just from this morning of the people that we have, the patients that are admitted that we have information on. 50% or 57 of those patients are unvaccinated. 2 of those patients are partially vaccinated. Basically, what that means is they got 1 of the 2 shots. And 2 of those patients are fully vaccinated. 18 of them we have incomplete information, meaning that that they weren't questioned when they were admitted through the emergency department or by one of the hospitalists. So we're seeking to close that so that we don't have any incomplete information. But just there alone, you can see the difference between 57 unvaccinated and 2 fully vaccinated who are now sick enough to be admitted to the hospital.
Sure. But Dr. Haidar, what is different about this COVID-19 Delta variant compared to the first wave that we had earlier this year? What are you seeing that's different, and how would you explain the impact of that difference on the
Yeah,
disease?
one of the first things we've noticed is that this is a lot more contagious. So previously, we've had patients that had COVID, were admitted to the hospital, but family members were actually spared, and didn't get it. Now we're seeing more and more that if one person gets COVID, most of the family gets affected. It's a very contagious virus. The R0 is about 5, which is about 2 to 2.5 times more contagious than the initial variant that we had. This is one thing that we're seeing. The other thing that we're seeing, which might be due to other issues, is we're seeing younger and younger patients come in. And I think that has something to do with that we've vaccinated the older population to a better rate. Maybe that has something to do with it. We're seeing, I spoke with Dr. Sadla and a few of the ICU team as well. We're seeing a lot more pulmonary fibrosis, and it's happening faster. And I'm also seeing a lot more lingering symptoms that last longer than usually. So the recovery phase has been worse than what we saw in the original or the wild strain, So these are some of the things that we're seeing. But the key one is it's a very contagious virus, and the R0 is 5, which is more than twice as contagious as the first one that we saw.
Okay.
And really, we've had many sad stories. One patient comes in, and then it's a matter of time before I expect other family members to be admitted with similar symptoms. So it's been a very very tough virus in that sense.
Could you talk about the late effects of the COVID-19 virus infections, such as the long haulers or other systemic or organ system issues that may come from having this virus?
Right. So, I'm going to talk about the COVID in general, because the Delta variant became the predominant one recently. So we haven't seen too much of, but I think it's going to be very similar to the original strain. We're seeing a lot of chronic lung issues. We're seeing a lot of fatigue. Some patients are taking them months to get their sense of taste and smell back, and a lot of psychiatric issues as well. Depression. Some patients has PTSD. So honestly, the long-term effects can be overwhelming, and patients usually, when they worry about COVID, they worry about the acute issue. This is what might happen to me. I get hospitalized. A lot of patients have been having multiple chronic issues, inflammatory response, joint issues. that have been lasting for weeks to months. And this is all very new. So a lot of the time, rheumatology is involved, neurology is involved, trying to figure out, what's the best way to approach the lingering effects of the virus.
Mhm. So let's get practical now. If I have cold symptoms, a runny nose, a slight cough, maybe a headache, I think, is this COVID or is this a cold? So what would you recommend that all of our caregivers and those in the public, how would you approach that? What would you recommend that they do?
This is a very tough question, and it's time sensitive. I think with how bad things are right now, and with the positivity rate that we're seeing in the emergency department, I think if anybody has any symptoms of URI symptoms, runny nose, sore throat, sinus pressure, or loss of sense of taste and smell, dry cough, even, I would definitely try to get tested. For two reasons. Number one is to minimize the effect, how infectious this virus is, and the sooner we find out if somebody has COVID, the sooner they can quarantine and do the right thing. And the rate is very, very high in the 8-9 counties that we service right now, and I really think we should not assume that this is probably just a flu or a respiratory virus. I think if somebody has access, they should get tested.
So that brings up, how do I get tested? Where do I get tested? So maybe Dr. Tucker,
Certainly.
if you could field that question for the Adina.
Certainly. So you have multiple options. Certainly, if you are quite ill, you've gotten something, the symptoms he's mentioned, cough, congestion, headache, fevers, chills, muscle aches, sore throat, and you start to become short of breath, we would recommend you actually go to see a provider to have an examination done and have your vitals checked. That is best done at the urgent cares or emergency department. If you are not having severe symptoms, we would encourage you to try to avoid the emergency department setting, because right now it's overwhelmed with people that are quite ill and there are long wait times. So it will be inconvenient for you in order to get a test. Your options include, and I'll call this at the entry level, many pharmacies are now selling at-home test kits. These are the antigen test kits made by Abbott and another manufacturer. I've looked at the data on those, and they're pretty reliable. They're pretty good as an entry-level test for people that are symptomatic. They're very easy to do at home by following the instructions, and they give you a result in 15 minutes. The downside here is that many of them are sold out. Many pharmacies, if you can find them, they will limit how many they will sell to you. Your next best testing option is going to be probably at one of the local pharmacies that offers a testing option, like CVS. Contact the pharmacy and they will have you follow their instructions, and you do that and they will get you a result within a reasonable period of time. We at the health system here had originally been doing some drive-through testing where it did not require a visit with a provider. As COVID first wave disappeared, those things were dialed back, and we've up until really here recently have been doing most of our testing in urgent cares. That is going to be changing on Monday, in which we are going to offer a drive-through testing option here out at the hospital campus at the PACCAR Center. So there'll be more information to flow on that, but you will be able to call and without being seen by a provider, have drive-through testing performed and get a result with a reasonable period of time. So those are the best options as they stand right now for getting a test.
Okay. So Jeff, I know that being out in the community, we both hear about the impact of COVID at Adina with the volumes. What are the other impacts that you've been hearing from the community on their care?
I think probably the wait times is the biggest thing, but what I've found is that the way people ask the question, it's really in an understanding way. People really understand. I think really the biggest point that I try to tell people when I'm talking to them in the community is, if you turn on a TV set, you watch the Ohio State game last week, you go down the street, you would think life is as normal as can be. And we are at the point of as Dr. Haidar and Dr. Tucker has explained, the worst it's ever been. And precautions, masking, vaccine, those are the biggest things to help us get through this. But really, as far as a community concern from the hospital, I wouldn't say that we've had concern, but if anything, the continued support and prayers. I get a lot of people talking about prayers for our caregivers. Continue to do that. Please continue to do that. These people are working really hard 7 days a week, and everybody's pitching in. And it might look like outside the normal world here that it's normal, but it's not. And for us, it's really tough right now. So we would appreciate that.
Yep. Everybody can do something, and that's pray for those who are suffering from COVID, those who are caring for those suffering from COVID. So, Dr. Haidar, we have lots of people that are vaccinated, and those people who are vaccinated are being asked to wear masks indoors. Why would that be?
That's a good question. First of all, the vaccines work great, and you look at the numbers. They decrease hospital admissions and mortality by 17-fold. But just like if you go in a car and you have an airbag, it doesn't mean you don't put your seatbelt. So it's effective, but not 100%, the vaccine. Add to it the other level of protection, which is the mask, and just the combination of multiple levels of doing things give you the best protection. And that's really what it comes down to. And the other reason why, let's say, of course, I'm vaccinated, I don't wear my mask, I might not get COVID, and if I get the virus, I won't have any symptoms, but I can still spread it to other people. So you're not only worried about yourself, you're worried about your community, about your loved one, about family members that might, have immune response issues and don't do well if they get COVID. So it's really, it's a multi-layer approach to having the most effective way to fight this pandemic, So that's in a summary why I think we do what we do.
So one of the things that I know is nothing is 100% effective. So if we deploy all of these things, the vaccine, a mask, hand washing, isolating yourself if you have symptoms, staying 6 feet away from others in a crowded environment, the objective is to maximize every single component of that so that we decrease that transmission of the virus.
Yeah.
So that answered a question from a viewer. Another question is, can I get a flu shot and a COVID vaccine at the same time?
Absolutely.
Yes,
The CDC
go
has
ahead,
cleared that, and we thought we were going to have the opportunity to test that with the booster information potentially coming out at the same time as flu season. But that has been okayed, although I do not think that anyone will have to worry about that too much. Flu shots are now out and available throughout the community. If you're worried about getting them both at once, I would just go out right now, take advantage of that flu shot. So when the booster stuff starts coming through here in about 2 weeks, you'll be well aware and apart from that flu shot.
So let's circle back around to the booster, because that's the question that I get the most. I saw patients this morning. That was the question of the day. So I know that the Pfizer has been approved for a booster for a subset of people. Can you talk about who those people are, and then what is the prediction of how that booster will come through?
Okay. So as you said, Dr. Gabus, the booster has been approved for only a subset of patients that we feel if we give them a third dose of the vaccine, their immune response might be better at fighting the infection. So these are patients that are immunosuppressed, that don't have the immune system to produce the right immunoglobulin, the IgGs to fight the infection. And the subset includes people that have like solid transplant, patients that are on high-dose steroids, immunosuppressive treatment for any kind of autoimmune disease, and of course people on chemotherapy for cancer. So that's the subset. But I think today the immunization committee met, and they added to it. Now they're recommending it to all seniors. which is no one on this panel, of course, but to seniors as of now. But it's still there's no official recommendation to give it to everyone at this point. Only people that have immunosuppressed status, high risk if they get it. And today, but this is not confirmed, I haven't get the official report, that I think the recommendation is going to be to all senior citizens.
You and I know what immunosuppressed means.
Right.
Can you give some guidelines to our viewership who think, well, is that me or is that not me? So what are some examples of a person whose immune system isn't working right?
Okay. Some examples, but there's a lot. Include anybody that had a history of transplant, solid organ, kidneys or liver transplant, or bone marrow transplant, any patient that has cancer and is having chemotherapy, any patient that has autoimmune disease like lupus or rheumatoid arthritis, and taking medications that suppress your immune system like Cellcept or methotrexate. Also patients that have inflammatory bowel disease and then are on what we call DMARDs like Remicade or Humira, psoriatic arthritis. So this is some subset of the patients that their immune system is not doing great on its own. And we feel if we give a third dose, which is the booster shot, they have a better response.
Okay, so we've talked about avoidance and trying to prevent the virus from attacking you. We've talked about if you're seriously ill, we're going to take care of you. If you're moderately ill, you may come to the hospital and we may send you back home with close contact. What about the monoclonal antibody infusion? Because that's something that I've seen it turn around somebody who's had COVID, and it's been very, very impressive. So Dr. Tucker, how would that be used to treat COVID?
Sure. So just so that everybody understands, this is different than a vaccine. So you're not getting a vaccine with this treatment. What a monoclonal antibody is most of us know that when we either get an infection naturally or we're vaccinated against an infection, like we get a flu shot, our own immune system develops antibodies against that infection. And then that protects us the next time we're exposed to that infectious agent, like a virus or a bacteria. So these monoclonal antibodies are basically synthesized antibodies. They're pre-made against coronavirus, so that in individuals who have either a very high-risk exposure, like a close contact, and might be at risk for getting very, very sick, like somebody who is immunocompromised, or somebody who actually shows signs or symptoms of coronavirus, tests positive, and is also at high risk of progression to severe disease. And those things are usually people over 65, people with other chronic conditions like diabetes or heart disease, kidney disease, lung disease. They can receive this treatment, right, which is synthesized antibodies. They are generally either given as an injection under the skin or an IV infusion. And many of these folks show significant improvement in their symptoms within 48 hours. The major outcome piece of this that they studied when the FDA approved these for emergency use or authorized them for emergency use was a reduction in the likelihood that you would keep getting sicker and sicker and end up hospitalized with COVID. So if you end up with COVID and you speak to your provider, either in the emergency room or urgent care or primary care provider, they do have access for the right patients. And again, they have to meet these criteria. You have to be older or have some chronic disease for consideration for one of these therapies. And we are doing these therapies, these infusions, here at the main campus at Adena Regional. We're doing them at Adena Pike and at Adena Fayette. So they are available for people who meet the criteria.
So if you're seeing your primary care provider, that's a good question to ask.
Yes.
All right. Another question from a viewer is, if someone's been in contact with a person who found out that they have COVID the next day, should I get tested or quarantine? Dr. Haidar, you want to tackle that one?
So if someone just had been exposed within 24 hours, first I would quarantine definitely. And I would test within 3 to 5 days, because that's when the test becomes the most effective in terms of finding the answer. I would say that timeline would be the best way to do this. So if I get exposed on a Sunday, I would call work, quarantine. If I get tested on a Tuesday or a Wednesday, then the test is a lot more sensitive and specific. It has a better value to give you if it's a true positive or a true negative.
So it takes some time for the virus to replicate to be discovered.
Exactly.
With the test.
Yes, because if I get exposed and I get tested within hours, my nasal passages have not had enough time to replicate the virus, so the test sometimes is falsely negative.
Mm-hmm. Here's a question also from a viewer that is important as this disease is affecting younger people, and the vaccine is going to be available for younger people in the future. Does the vaccine impact fertility?
Okay, sure. You want to answer?
No, at this point in time, this vaccine has now been given to over 200 million people, men, women, and children over 16. Pfizer and Moderna have both been running studies on children over 5 and the safety of this vaccination. There is currently no evidence to suggest that this affects short-term or long-term fertility, and it is recommended by the American College of Obstetrics and Gynecology. Part of the reason for that is even in pregnant women, being pregnant is one of the big risk factors for severe progression of this disease. So if you are pregnant or are planning on becoming pregnant in the near term, being vaccinated is a very wise choice for you at this point in time.
Okay.
So and just to add, so miscarriage in pregnant females that have been vaccinated is exactly within the average of the number of miscarriages that happens across the board. So really, there's no evidence based that this causes infertility, and just like Dr. Tucker said, it's strongly recommended for pregnant women because they can advance to severe COVID.
Okay. Another good question that I hear all the time, can you get a Pfizer booster if you've had the Moderna vaccine and vice versa, or the Johnson & Johnson?
Can I answer that
Yes.
one? So as of now, the data is not out there to recommend it or to even suggest it. Now, I'm sure you guys know, I grew up in Canada. In Canada, they're mixing and matching, so you can go for a Moderna. But in the U.S., we don't have enough data. We don't have any scientific information to recommend it. So I would still recommend, if someone has taken Moderna, to stick to Moderna. If somebody has taken Pfizer, to stick to Pfizer. And Johnson & Johnson will probably be doing the same thing soon with the booster. So no mixing and matching as of now.
I agree.
Okay. So we've talked a lot about a lot of different things surrounding COVID-19, especially the Delta variant. There are controversial aspects of this, whether to get vaccinated or not, and how people are feeling like they're being stigmatized. What's the stance of Adena Health System on if you're not vaccinated? I know we talked about testing, but I want to be sure that we're addressing that.
Yeah, that's a great question. And also, I think it's great, all the questions we're getting in. And that's really the purpose of having an opportunity like this where we can reach out and talk to people, because you guys are asking some great questions. And as I always say in our internal town halls, there's no wrong questions. So please ask. So thank you. Keep those coming. Our stance, I'll go back to what our stance is on people being vaccinated. It's a choice, right? And our view is we don't look upon someone that has made a choice differently than we do those that have made a choice to get the vaccine. I mean, unfortunately, to your point, it's a hot button out there. When you look at the vaccination rate of just say Ross County is, what'd you say, 41%, something like that? So based on that number, and it could, plus or minus factor, you can see kind of where the communities are split on this. And so it is a hot topic, but Adena's perspective on it would be, we respect people's choices, but we also here at the health system are going to take every precaution and strongly encourage those to take the vaccine that work here.
Okay.
Does that answer your question?
It did. It did. Dr. Tucker, how do you respond to those controversial?
I want to emphasize that I personally don't look at this as a matter of people being right or wrong. When you look at the normal groupings of human beings, there are people that are called early adopters, and there are folks that have a little bit more skepticism. And if the whole world was full of early adopters, we probably all would have been dead at the bottom of the ocean hundreds or even thousands of years ago. So it's good to have a mix of healthy skeptics and folks willing to go out and do things sometimes with a little less evidence. In the end, that leads to a good balance. So I agree with Mr. Graham that people have a choice. I can tell you that as we get further and further along in this pandemic with Delta, that my concerns are that younger and younger people, healthier and healthier people that have chosen to wait on the vaccine is becoming more and more heartbreaking. For me personally, I made a decision for myself and my family. They made their decisions on what to do with the vaccination. I would encourage you that if you're still on the fence, right, to talk to somebody you trust. Dr. Gabus has taken care of people for many years, and I'm sure that they trust his opinion. I let my patients know I would never do anything if I even remotely thought it could be dangerous or hurtful to them. So I think it's very important that there's no right or wrong in this, and to talk to people that you trust and you have trusted with your life for decades over decades. So.
I agree.
Dr. Haidar, do you have any other words of wisdom in that category?
Honestly, I believe in vaccine clearly, but I also believe in choice, and I think people are intelligent and know what's right for them. I only hope that people get the right information so they can make an informed decision. And so yes, I respect people's choices, and I never pass judgment. But I hope that everybody gets the right information, and information will change. That's science. What we think is right now might change, on how many cases of myocarditis we might get with a certain vaccine. Transparency is important, information is important, and informed, decision is important. So that's what I think.
I think if I could just tag
Sure.
onto that, I think what Dr. Haidar said there is very, very important. It's about getting the facts and making your choices, because there's so many things. I heard someone say this, or I read it on social media. For me personally, I'm going to trust my physician primary care.
Right.
The people to inform me and ask me questions, or seek out the source and best making your choice.
What are some of the websites or sources of true information?
That's great.
Or
Sure.
are you recommending that your patients? So if I want to go educate myself,
Right.
what are some of the sources that you would direct me to?
So I know that when people are talking about both sides of this, there's a lot of people, and rightly so, have developed some skepticism about, like, the CDC, that there's been some confusing information, even very early on, about masks or not masks and how protective they were. So at this point in time, if you want to go to sources that I consider reliable and not government linked, I've been through the WebMD literature, and I find it very reliable and written for a level that you can understand if you have questions about how does this vaccine work? What are the realistic potential side effects I can experience? I'm worried about this one side effect, and I want to know how often that happens. Making sure that you're looking at something that is scrutinized heavily, and it's not just any one person's opinion is the way to go. Now, certainly, the CDC is still a very reliable source for accessing information. But if you have trust issues with that, there's other places like WebMD. And then certainly the ADINA website's also very helpful.
Absolutely.
And I know that ADINA is working hard at keeping the social media environments full of good, trustworthy information.
Yeah, I would say just continue to look at our website and look for information, because we are doing everything we can to push information out, because we know people want to know.
Right.
Right.
Here's another question from a viewer. Why aren't the monoclonal antibodies offered to the general public?
Okay, good question. There's two principles about giving those monoclonal antibodies out. Number one, it's not a pill. Okay, so if you're going to get this, it's either an injection into your stomach or side, or an infusion where we put it in an IV. That infusion is run in over an hour under the supervision of a registered nurse, which, as you've already heard, are in short supply. And then we have to sit and observe you for an hour after that is infused. So this is also not in limitless supply. So we count the amount that we're distributed every week on the monoclonal antibody infusions. So we only have so much of it, and we only have so many people that can infuse it. So there have been very strict criteria developed about who best to deploy it on, who benefits the most from it. It tends to be people that are at high risk for getting very, very ill.
And if I may point out, you have to have a positive test.
Yes.
And you have to be at risk for developing progressive symptoms. And the objective is to keep you out of the hospital.
Yes.
Is to have you not get so sick.
To arrest the progression of the viral infections that you don't end up hospitalized.
So another hot topic that we haven't touched on yet, Ivermectin and other treatments, hydroxychloroquine. So that's a hot button, and people are saying, well, if they're coming into the hospital with COVID, they're saying, I want Ivermectin. How would we address that?
Well, go ahead.
Sure. So we need to have a little bit of a historic perspective. The way we practice medicine, the way medical field is set up is there's a medication that we need, and we check to see first, is it effective and does it have side effects? Because we have first do no harm. So if this medication is effective and it causes the side effects might be justifiable, then that's clearly something we might be able to use. There have been multiple reports of ivermectin, started in South America. I think Argentina was the first country that said that it can actually take care of the COVID syndrome. But multiple studies as of now have negated that study. And apparently the concentration of ivermectin that you need in a petri dish to kill the SARS-CoV-2 virus is probably 50 times the concentration that we take from a pill. So now, all of that being said, there's at least 6 trials going on right now. Some from WashU at St. Louis, some from Malaysia, to see if ivermectin works. And that's the beauty of science. If something works, we'll be more than happy to use it, but we need the evidence behind it. And that's the only fair way to treat your patient, is to say, hey, this medication, I really don't think it works. It has side effects. I'm not going to give it to you because I can do harm. Right. Personally, there's fluvoxamine. Remember, we've talked about, there's actual clinical trials going on that, hydroxychloroquine, ivermectin. So it's not, no, we're not going to use it. As of now, there's no evidence-based medicine that it works. And the evidence that some people have quoted is it's very weak in terms of statistical analysis. When you look at how many patients there were, how did they cohort them, all this stuff. So if you really get into the nitty-gritty of it, we don't have any true evidence that this works. And if it does, but we're still, clinical trials are going on. If it starts working, then I'll be the first one to want to use it, because we only have one objective, for our patients to get better. And I don't care if I'm going to use essential oils or whatever works, we'll be happy to use, but we need the evidence. And that's how science works. It's not like my cousin took it and they felt better, and that's not evidence, and that's where it gets complicated.
So at this point in time, we're not using it at Adena Health System or within our treatment facilities. I know a lot of people say, oh, that's because it's cheap and it's effective and you want to give us the expensive stuff. Well, it just so happens that the most effective therapy for those sick enough to be admitted to the hospital in respiratory failure with COVID pneumonia is dexamethasone, a cheap steroid that costs pennies on the dollar. Has actually been shown to reduce mortality. It reduces people dying from COVID if they are severely ill. So that's not the MO of the organization. And as Dr. Haidar says, if we can get some solid evidence-based outcomes that show that it's effective, we're prepared to turn on a dime and administer whatever we have that's available to us that might help. But all of us are sworn to first doing no harm. You couldn't pay me money enough to take ivermectin in the doses that they are currently putting out there to treat COVID-19. It would be frankly dangerous. It's dangerous to do so.
Well, that was very timely answer, because one of the last questions that we received is, what treatments are being done for patients hospitalized with COVID? Dexamethasone, remdesivir, other supportive treatments.
Yeah. So at its current state, we have what appears to be a medicine that acts like an antibiotic, the remdesivir. So that's infused in people who meet criteria. The dexamethasone is a steroid, and what we think it does is it blunts the overreactive immune response to this virus being present deep in your lungs, which we think causes some of the damage that results in the need for eventually the use of a ventilator. We certainly use oxygen in all forms, from just the little thing you all are used to seeing on people's noses, that's low flow oxygen, to more higher concentrations and high flow oxygen. You might hear things like Neptune. That's where we heat the gas so it can really flow fast. All the way up through BiPAP, which is where we put a literal pump on your face, shoving air in and out of your lungs. And then, of course, the big one, which is the ventilator, the tube down the throat that can put it in under high pressure. Breathing treatments. So you guys know of asthmatics that use albuterol. That's a cornerstone of treatment on the floor for this condition as well. So am I missing anything, Doctor?
No, I think we're using tocilizumab, which is an interleukin 6. We have a JK inhibitor. Honestly, anything that is approved, we have access to it and we use it here. And there's anything that is approved that we don't have access to or we can't use. So, that's a blessing, because we do have access to all the medications that we need to treat the patient with the utmost care.
All right. Wow, we've covered a lot of territory. Vaccines, the response of Adina, the volume. Jeff, I'll throw it back to you if you have any closing comments or things that you want our viewers to know in terms of the commitment of Adina to their health.
Absolutely. As I've said before, our people, they've never stopped, and they're continuing to work hard. I always say it's neighbors, family, and friends, taking care of neighbors, family, and friends. And so please, you see one of the Adina caregivers, somebody with an Adina badge on, give them a big thanks, because they are working really, really hard. Last parting words, I've said this on previous shows, the best precaution is your distance, the masking, and get vaccinated. Look at the numbers, do your research, but look at our numbers of who's actually going in the hospital versus being vaccinated or not. And I would highly recommend, strongly recommend that we do that.
Okay, to highlight that, I know that through the program you've seen the locations for vaccinations through Adina, also through commercial pharmacies. Please be sure to reference that. It's on the screen right now for you to see. You don't have to be a patient at any of these sites. We are offering this vaccine at no cost to you, wherever you can get it. Our objective is we want you to get it. So thank you so very much for joining us today for this community town hall update on COVID-19. Please stay safe, wash your hands, wear your masks, and if you're able to, get vaccinated. Have a good day.